Hello and welcome. My name is Dr. John Corino. I'm a prosthodontist. Today I'd like to share with you a new paradigm shift in implant prosthetics. Before this, we only had two options, screw-retained crowns and cementable crowns. Now we have a new way of restoring implants that gives us the best of both worlds. I hope you enjoy my lecture. Welcome to a paradigm shift in implant prosthetics by RODO Medical. It is the art and science of the smile. It's an original lecture series. This is recorded as a review for my lecture attendees on July 8th, 2017. Today we're going to discuss a number of implant topics. Screw retained versus cement retained. What does the literature say? Smile lock technology. We're going to look at smile lock for the single unit, parts and accessories, smile lock removers, bridge work and full arch restorations, and what's currently going on in research and development. A little about me. I am a prosthodontist. Graduated from Emory University School of Dentistry back when they had a dental school. From there I continued my education with my dental implantology certification at Harvard University. I have an office in New Providence, New Jersey, a sleepy little town 30 miles west of New York City. A bedroom community for the financial district. Like most towns in the Northeast, there's a memorial tribute for those lost during 9/11. Here's my office, right by the train station. This is my crew. I have a partner. We share two dental assistants. We share two hygienists. We have an office manager and a lab tech. Let's talk about the implant conundrums. When I started, back in the mid-80s, there was screw-retained versus cement implant restorations. That's all we had. Bränemark had the external hex. He restored his cases with a high water line. Straumann and the ITI, simultaneously in Europe, developed the tissue-level implant with the cementable abutment. I think we could all agree that the father of modern dental osseointegration is Per-Inge Bränemark, an orthopedic surgeon out of Sweden. He was the one that developed the first dental implant system, and this is one of his original case studies, done on a rabbit femur. The man sitting to the left of a young Per-Inge Bränemark is just as famous. His name is Gustav Larsson, a cab driver from Stockholm. This is Per-Inge Bränemark's first implant patient. A high water line, maxillary mandibular arches. Nothing touched the tissue. Basically, it was a bar with polymethyl methacrylate and denture teeth. Gustav Larsson wore this for a little over 40 years. So let's talk about some of the screw-retained advantages. One, they're easier to retrieve. Hygiene and maintenance is easy because we could take them off. If we have to change the emergence profile, we can. We can close a contact if one becomes open. If there's an adjacent tooth loss, we could add it to the prosthesis. And we could change the prosthetic design if it's retrievable. And it's really the only option when there's limited inner arch space. The other main advantage of screw-retained prosthetics is its known retention, and there's no risk of leaving any residual cement. Let's see what's corroborated with the literature. It was Wei and Hidehiro in the International Journal of Prosthodontics back in 2008 and 2010, where they studied 146 restorations that were placed, and they evaluated them from anywhere between a 1 to 123 month time period. 43% of those restorations developed an open interproximal contact, most commonly on the mesial. The greatest incidence of development was with patients with opposing dentition of natural teeth, or implants, and teeth adjacent to the implant restorations were non-vital and non-splinted. In my practice, we see this frequently. As you can see here, the screw-retained crown on the left-hand side with an open mesial contact. Cemented crown on the right-hand side, open mesial contact. And again, Straumann implants, mesial open contact on the second bicuspid. Screw-retained has disadvantages though. One being the cost. Extra screws, set screws, the aesthetics aren't as good, the composite plugs darken with age, and implant position is very, very critical. Angled abutments, impression parts, lab analogs, lab screws, metal bills, the set screws, the abutment screws, milled cores, prosthetic screws, and lab bills really raise the cost of the final prosthetics. You can see here 3 of my cases. Mandibular arch on the upper left-hand side, prosthetically perfect. Everything was great, except the patient says to me, "Why do my teeth have measles?" The middle slide with the set screws covered with silicone. "Doc, I still feel those little areas when the silicone pops out." And the one on the right, my little grandmother patient who came in and said, "My grandson says I have transformer teeth." All these cases were prosthetically working very well. Unfortunately, aesthetically, I missed the mark. Let's talk about some of the screw-retained disadvantages. You need enough room to get a driver through the restoration. There's limited opening, can hinder the access, and a loose screw always needs replacement. This is a maxillary arch restoration that I did, where the lingual set screws were very, very difficult to go ahead and place and lock down because of small arch and because of difficulty with this patient's opening. Straumann's screw-retained solution was the VarioBase. Whenever I do these, and I've done these historically, make sure you have the parts delivered separately. Never have them luted together by the lab. They come as the core and the crown, and then they'll come as the VarioBase abutment. Unfortunately, they got the heights right now. They make them a little taller than they did initially. Some of the examples that I've done clinically are right here. One of the issues that I've had with these is when they do come luted together and an adjustment has to be made, whether occlusally or interproximally, unfortunately you can't get the parts separated if they are luted together. If you lute them yourself, you have the ability to refire the crowns if need be, especially if there's a color issue. And you can see on the lower right-hand side, even with the composite plugs over the top of the access openings, it's a very, very aesthetic crown. Cement has advantages. Some of them are, obviously, it's a less complex system. It's a faster delivery. It's much more aesthetic. It's a simplified dental procedure. And the implant position is much less critical. One of the problems with cemented crowns is it's not easily retrievable. There's an unknown retention with these. You need a lot more inner arch space, especially if the crown and bridge margin is brought near the free gingival margin. And the biggest problem is we are terrible at removing cement. Here's one of my cases. Patient had a crown restored on tooth number 9. Went fishing down in Florida, and unfortunately, crown came out because no fisherman uses a knife or a scissor to cut a line. They always use their front teeth. Came back with this inflammation after having it cemented in Florida. Radiograph shows me that everything from the bone is still in good shape. I get the crown off, look at the cement around the apical portion of the crown. Look at the hair on the left picture. If we can't remove cement on a crown that's in the anterior portion of the mouth, how are we going to do it in the posterior portion of the mouth? I cleaned everything up, and here he is 4 weeks later. If he would only brush his teeth, I can get the gingiva perfect. But here are some other issues. That full arch on the left-hand side of your screen, patient was at a cocktail party during Christmas, bit down on an olive of a martini thinking there was no pit in it, and unfortunately fractured number 9. How would I restore that if this was a cemented case? With a veneer, I could, but because the case was retrievable, I was able to remove the bridge, redo all the porcelain, and place her back into perfect occlusion. On the right side, you could see that molar, all the lingual porcelain is fractured. I can't fix that. That crown's going to have to be redone. There was a study done by the American College of Prosthodontists, and they asked all U.S.-based graduate prosthetic residencies 2 very, very important questions. What cements are you teaching your residents to use for crown and bridge retained by implants? And what cements do the professors use for the same procedures? Now, in an ideal world, the answer should be the same, but it's not. What they're teaching is cement with resin-modified glass ionomer. What they're using themselves? ZOE. So what would be an ideal implant cement? One, you'd want it retentive. You'd want it radio-opaque just in case you left anything underneath gum line. You'd like to see it on an x-ray. You'd like it soluble. You want the proper viscosity of this. You'd like it hypoallergenic, some form of bacterial static or bactericidal, a neutral pH so you don't upset the gingival tissues. You don't want shade or value of the restoration altered in any way, shape, or form, because you'd rather not be altering the color of the crown. You want it retrievable at the appropriate time. You definitely want it non-reactive with titanium and zirconia. And it should not contain fluoride. Does anybody in the audience know what the name of that cement is? Unfortunately, it doesn't exist. If you invent this cement, your dental career is going to branch off in a whole new direction. Personally, with implant cements, KTB, Kirsch Tempon, is my implant cement of choice. If I have a non-retentive abutment, I use ZOP. So what does the literature say? Back in 2009, Tom Wilson, down in Dallas, he's a periodontist, coined the term peri-implantitis. He had 39 patients with 42 implants that had periodontal disease. 12 patients had implants without periodontal disease. He did an endoscopic study, and it showed residual cement around the implant. 76% of these patients got better when the excess cement was removed. The biopsies found cement in the soft tissues and titanium in the peri-implant tissues. So the cement was beginning to dissolve some of the titanium. We could see here, on the slide to the left, anterior tooth, cement along the long axis of the implant. On the right, posterior tooth, with cement along the long axis of the implant. Single crown failure, 11%, is because peri-implantitis, according to the literature. Cement-related peri-implant diseases is at least 10%. And 80% of implantitis is associated with cement. It was Wadhwani in the Journal of Prosthetic Dentistry back in 2010 took Wilson's studies a little bit further. He saw that peri-implantitis post-cementation of a crown was seen in its earliest stages of 4 months, in its longest stages 111 months, with the average being 30 months before peri-implantitis was seen clinically. It was Klauber back in the 90s that looked at titanium and titanium alloy implants and said, what corrodes these things? Acids being one, not just food, but bacteria, acids. In addition, chemicals. Fluoride corrodes titanium. Well, last time I checked, fluoride is one of the main ingredients in toothpaste. So what are we doing? And the other thing that we can't use with titanium is polycarboxylate cements. So Duralon cement is definitely out because you will corrode the titanium. So what happens when a cemented implant crown fails? The literature studies suggest that in the hands of experienced clinicians, complications occur frequently enough to concern clinicians of lesser experience. Cemented crowns require anesthesia and destroy the prosthesis. This causes pain and costs thousands of dollars to the patient. "30 to 60 minutes to remove it, re-impression it, get a healing cap or make it provisional." This is one of the reasons why I don't like cementing implant crowns. What are some of the comparative studies? It was Korsch in 2015 in a Quintessence article noticed that screw loosening on screw-retained prosthetics happens 3 times as often than on cemented restorations. Well, in actuality, this wouldn't be a bad thing because if it's screw-retained and it gets loose, we could always retighten it. If this happened more on the cemented crowns, it would be a big problem. Also, screw-retained restorations fracture at a higher rate than cementable restorations. And Nissen, back in 2011, did a retrospective study and came up with that knowledge. Screw-retained implant crowns failures. Where does this happen? Well, it happens where the weakest portion of the prosthetics is going to be. Usually on the buccal aspects of mandibular teeth, usually on the lingual aspects of maxillary teeth. Wherever the prosthetics is the thinnest, that is where your fractures are going to take place. And we see this in the literature. What else does the literature tell us? When we seat our crowns, using shim stock on the interproximals to measure the contact strength is paramount. With the 5-year survival rate study done by Saylor, we see that cementable crowns have a greater survival rate than screw-retained. We saw that fixed partial dentures, though, are better with screw retained. And with full arch over a 5-year survival rate, cementable has the greater longevity. So what can we say? Both systems work very, very well, but they both fail catastrophically. Cemented restorations fail biologically. Screw retained restorations fail mechanically. Be careful with both. Choose your restorations wisely. So current implant restorative techniques. Cement retention versus screw retention. 85% of the prosthetics performed on dental implants in the United States are cementable. It's only 15% that are screw retained. That paradigm is shifting though now. Both have a very, very strong following. Cementable is easy to use. The aesthetics are beautiful. Screw retained has retrievability. Can we combine the two? Can we have ease of use and aesthetically pleasing and retrievable? Is that possible? Well, this is how we combine the best of both worlds. RODO Medical. Welcome to the RODO abutment. It's a stock abutment that comes in a collar height of 1, 2, and 3 millimeters. It's retained by an abutment screw. The coping is luted to the underside of the crown. The smile lock transitions the coping to the retentive aspects of the abutment. Through magnetic conductivity, watch what happens to the smile lock. For those who missed it, let's watch it one more time. Welcome to the world of memory metal. This technology is going to change how implant prosthetics is performed. Basically, we have an abutment that gets screwed into an implant. We have a smile lock sleeve that gets placed over the abutment that has wings. We have a coping that gets luted under a crown, and the coping crown combination gets snapped onto the smile lock. We're going to go through this a number of times so we all understand what's happening. Currently, let's compare the prosthetic options. On the right-hand side of your screen, you could see a standard abutment that has an implant crown placed on it and is retained by a prosthetic screw. In the middle of the screen, you see a cemented crown that is either retained by a custom abutment or a stock abutment. Each of those abutments is screwed into the implant. On the left-hand side of your screen, we have the RODO abutment. The crown has a coping luted underneath it. The abutment is screwed into the implant, and the smile lock sleeve transitions the retention between the abutment and the crown and is retrievable. So how does that work? Well, we're using nitinol. One, because it retains its shape. When it's heated to a certain degree, it'll go back to that shape. Orthodontists have been using this now for a decade because it's super elastic. The cardiologists use this for heart stents. The endodontists have been using this for their files for the last 10 years. Welcome to the world of memory metal. Here we see a nitinol paperclip that's bent out of shape, then wrapped around a pencil. When we place it in a certain temperature of water, you're going to see it go back to its original shape. 2.8 seconds to rebound. So how does this work with the smile lock? So what happens is that washer has inner flaps and outer flaps, which are now called arms. The inner arms are engaging the coronal undercut of the abutment. The outer arms are flared in anticipation of engaging the internal aspect of the coping once it is placed. It's basically engaging undercuts. Let's go through one clinically. So, here we take the RODO abutment and that gets placed into the implant. The smile lock sleeve then gets placed and engaged in the undercut in the abutment. Then we take the crown and lute it to the coping. Once we have that done and the cement is cleared off, then we can go ahead and take the crown coping combination and snap it on to the Smile Lock and RODO abutment. That's what the abutment looks like. There's the Smile Lock in the mouth on the abutment with the arms, the outer arms, flared to eventually engage the coping. The two holes on the lingual aspect of the crown are what are used to access the coping to warm the Smile Lock to disengage if necessary. There's a radiograph of the seated prosthesis. So again, we have a crown. The crown has the coping luted underneath it. We have a RODO Smile Lock that engages the RODO abutment and also engages the internal aspect of the coping. The inner flaps of the Smile Lock sleeve engage the coronal portion of the RODO abutment. The outer arms of the Smile Lock sleeve will be engaging the undercuts in the coping that's luted to the crown. And you can see in the cross section how this is engaged. It's basically engaging undercuts. And there's the cross section. You can see on the upper right hand side the inner flaps engage the abutment undercut. On the lower right hand side the outer arms engage the undercuts in the coping. Now Smile Lock engineered forgiveness with this. So when the lab fabricates our crowns, they have a tight fit. They have zero forgiveness. There is no give at all. When we get the crowns from our labs, there is a 25 micron forgiveness. With full arch, there is a 50 micron forgiveness. Because we have to be able to eventually snap it on and get it off if we ever want to, especially with maintenance on bridge work. So the outer flaps and the inner flaps both being engaged and retaining a crown. When heat is applied, the sleeve unlocks and the crown is retrievable. So think about this. Fully aesthetic crowns that are retrievable at will. The first generation Smile Lock remover was what you see here. It had two prongs. It was battery operated. The two probes went into the two lingual aspect holes on the crowns. It warmed the Smile Lock to disengage. Second generation was the dental laser. It was portable and handheld. There was non-contact activation possible if the laser was powerful enough. But the handheld laser, which had the 3 watts of power, required one lingual access hole, as you can see here. Same short time regardless of the prosthetic materials to remove it. The cons was there was at least one lingual hole. And that's basically all you needed. You had to engage that access opening. The non-contact activation with portable laser doesn't require holes on the lingual aspect of the crowns anymore. What is in development at this point is the magnetic induction Smile Lock remover. That should be introduced by the end of the year. So let me show you how easy this is to use. This is in beta testing now. So basically you go over the area where the implant is, where the Smile Lock is. All you need is 5 seconds per Smile Lock. After engaging or disengaging all 4, the prosthesis is removed. Here's the history of the Smile Lock removers. On the left, the resistance model requiring holes on the lingual aspect of the crowns. Now all the way to the right, where there's no contact through holes. It's a solid crown, and it's using magnetic induction to unlock the Smile Lock. Nickel titanium goes through phase changes. In its most stable condition, it is considered austenite. And you can see at the top of the screen, the lattice pattern is very even. When that metal is cooled, it becomes martensite. And while it's in the lattice pattern of martensite, it is able to be deformed. As you can see on the lower right-hand side, deforming into the lower left-hand side lattice pattern. Once it is deformed martensite, in order to bring it back to the austenite shape, it has to be heated. So Smile Lock is memory metal that can be distorted. So you can see when it's in the austenite form, everything is smooth. When the Smile Lock sleeve is cooled, the metal changes to a lattice pattern that can be mechanically deformed to actively engage the undercuts in the RODO abutment and the coping. We have to bend the inner arms and the outer arms on the smile lock in order to retain the crown on the abutment. Deformation is achieved through the smile lock arm setter, as we will show you here. These are the three portions of the smile lock arm setter. There's the top portion, the bottom portion, and the push pin. How this works is we take a smile lock sleeve and place it on the bottom portion of the smile lock arm setter. The upper arms have to be in alignment with those 4 grooves on the bottom portion of the setter. And you can see here that that alignment has to be made prior to putting the top portion of the setter on the lower device. At this point, the push pins are gently pressed in all 4 lower holes to flare out the lower arms of the smile lock sleeve. As you can see, all 4 lower arms are flared. At this point, the smile lock seater can pick up the smile lock and be placed on the RODO abutment. So as we can see, when we're heating the device in the mouth, those flaps, the inner and outer flaps, will rebound and collapse, which allows us to remove the crown. The video helps explain it better. Just think about how easy these prosthetics will be to clean in the future. Occlusal contacts before and after placement of the smile lock are the same. And we don't have any more complications with cement, nor do we have any more complications with screw-retained prosthetics. Here's your abutment choices. So on straight crowns, there are 2-piece options. The only variables are the collar heights, which are now available in 1, 2, and 3 millimeters. We also have the angled abutments, the 17 degree and the 30 degree. So the taper of the RODO abutment is 20 degrees. So if you add the 17 and the 30, we have basically up to a 50 degree difference of angulation for full coverage. It's the same angled abutments that you find in Nobel, that you find in Neodent, that you find in Straumann. The 300 series is for the restoration of single crowns. The abutment height is 3.6 millimeters. The width is 5.5 millimeters. You can see where the smile lock will engage in the coronal portion of the abutment, and you see where the RODO coping will engage more so around the silicone seal of the abutment. Again, this is for single crown restoration. The 400 series abutment is for a wider tooth. It is still 3.6 millimeters in height, but the width is increased to 6.5 millimeters. The 500 series multi-unit abutment is for bridge and full arch restorations. The coronal portion of the RODO abutment engages the smile lock. The apical portion of the coping is sealed around the silicone. The 517 series is a multi-unit abutment, which is used for bridge work and full arch rehabilitation. It's a 17 degree angled abutment. The 530 series is also a multi-unit abutment. It is used for bridge work, full arch rehabilitation, and specifically for all-on-4. It engages with the implant. It does not engage with the coping. There's our choices. So literally one smile lock will fit the 300, the 500, the 517, and the 530 series. The only different smile lock that you would need is if you're in the 400 series for a wider crown. Here's our RODO product tree. Again, we have a two-piece abutment, we have a solid abutment. We have angled abutments at 17 and 30 degrees, and we also have abutment blanks that are going to be able to be milled. From our coping options, we have a temporary titanium abutment, we have a burnout coping, we have a titanium coping that gets luted into the underside of a crown, we have zirconia milled copings, and we also have coping blanks to be determined and introduced later on. From the smile locks, relatively simple. We have the 5mm, the 4mm, and eventually the 3mm. What's in the development pipeline is the CAD/CAM coping blank. That will be a customized coping using the smile lock technology. Here are some of the RODO accessories. We have a socket driver to basically torque in the abutment. We have a closed tray impression coping. We have temporary caps for healing. We have the smile lock seater, which actually seats the smile lock sleeve onto the abutment. We have the titanium coping, which gets luted into the underside of a crown. We have a temporary titanium coping in case we want to make a provisional. We have the abutment analogs. We have a bar analog. There's the lab sleeve, which is going to be different than the clinical sleeve that we're going to be using. We have the flap setter to engage the inner and outer arms of the smile lock. We have the seal seater to make sure the silicone ring is placed accordingly. And we have the hole fixture for the lingual access holes that are currently being used for crown and bridge. Again, here's your parts. We take impression copings just like we take impressions now. Provisional caps, abutment analogs, titanium copings for our crowns. You see the lab sleeve. The seal seater is for the silicone ring. There's the flap setter for the smile lock. And there's the holder for placement of the smile lock. Some of the drivers that are necessary is the Torx T6 driver. It's an angle abutment screw driver used in the 400 series abutment screw, also for the impression coping screw and the temporary cap screw. This is necessary with the 517 and 530 series abutments, the 400 series wide body, the impression coping, the temporary cap, and the temporary titanium coping. The socket driver is for the solid abutments. It's a bicuspid abutment integrated screwdriver used for the 500 series abutments as well as the 300 series abutments. So let's look at a Nobel all-on-4. We have angled abutments with abutment screws, abutment tapered screws, and prosthetic screws. Let's compare the RODO Medical Smile Lock all-on-4 parts. Here we have a 30-degree RODO abutment. Which gets retained by the abutment screw. The coping gets luted into the prosthesis. And the smile lock engages all the necessary undercuts. When necessary, through magnetic induction, the smile lock disengages. With the smile lock, we don't have any prosthetic screws. There's no screw access holes. There's no abutment tapped screws. The RODO abutments, both straight and angled, get screwed into the implants. The smile locks get placed and engaged in the coronal undercuts of the RODO abutment. So the smile lock sleeves then, that have been activated with their apical arms already widened, are now placed on the undercuts of the RODO abutments. And then the prosthesis is snapped onto those. So, no screw access holes, no abutment tap screws, no prosthetic screws. I'll show you this in a video. As you can see, the smile locks have had their lower arms flared. As they're seated, they are being engaged into the coronal undercuts on the RODO abutments. Once all four are seated, the mandibular prosthesis can be snapped on and retained by the lower flared arms. Here's a prosthesis with Smile Lock versus a prosthesis of All-on-4 for Nobel. Say goodbye to the fractures. We actually won't have screw access holes, resulting in a thinning of the prosthesis. So the first in-man feasibility study was done at UCLA in their prosthodontics department. They had 3 patients where crowns were retained intraorally for a week, and they had 6 patients where crowns were retained intraorally for 1, 3, and 6 months. The parameters for review were periodontally, probing depths, plaque scores, and gingival indices. Occlusal stability, they checked with shim stock, mylar strips, and T-scans. With mobility, they used the perio test and a clinical evaluation of the individual crowns. And they did a bacterial ingress test with microbiology cultures at 1 month to see if there was any bacterial contamination. They were done on Straumann, Nobel, Astra, and Biomed implants. And you could see there was no change with the plaque. There was no gingival indices change. Occlusal contacts were stable. Proximal contacts were stable. X-rays were all normal. Anywhere between 1 week to 6 months. They checked the occlusion with the T-scan, version 3, and you could see on the crown placement on tooth number 3 at 6 months, there was the same amount of occlusal contacts. Clinically, they went in to check for mobility, and they did a perio test. Mobilities were all normal. After removing the crowns, they did a Petri dish test to see if there was any bacterial contamination on any of the systems. Smile Lock, as you can see because of the silicone seal, no bacterial growth. Screw retained on the right after 1 month, had bacterial growth. Smile Lock system after 6 months of clinical use, there was no degradation in performance of the Smile Lock, of a used Smile Lock compared to a new Smile Lock. Retention forces also were greater than Panavia, Scotch Bond, Keytac, and Improv. In an ASTM F2129 pitting and crevice corrosion test, the test was conducted in a worst-case scenario. In other words, where the coping disengaged and the Smile Lock was exposed to the oral cavity. What they found was superior corrosion resistance compared to orthodontic arch wires. The auger analysis shows that there was good nickel-free protective titanium oxide layers around the Smile Lock, resulting in no nickel leaching into our systems. As you can see here, the tests were conducted under worst-case scenarios, and they compared them to orthodontic wire. So, the average daily nickel consumption allowance by the FDA is anywhere between 69 to 162 milligrams per day. With orthodontic wire, being of nitinol, you'll get 13 milligrams per day release. With the RODO Smile Lock, 0.1 milligrams per day at its peak. These studies precipitated the FDA 501(k) clinical study, 32 patients with 41 implants, 3 full arches, 29 single crowns. 16 cases were done at Clear Choice in San Jose. Had 4 implant systems, 21 being Straumann, 12 being Nobel, 4 implants being BioHorizon, and 4 being Biomed 3i. This got Smile Lock FDA clearance November of 2016. So, who's part of the medical overview teams? Ben Wu, for one. He's the chairman of the board. Professor and chairman at UCLA. And for those familiar with prosthetic dentistry, I am sure you're very familiar with everyone on that page. The advisory board, Ole Jensen heads that, as well as the contributing notables pictured underneath him. Seated in front of you from left to right is Gino DeSimone, Young Su, and Ben Wu. They are the principal driving force for RODO Medical. The dozen or so people behind them is the principal lecture force for RODO Medical. I am honored and happy to be one of them. I want to thank you all for coming to the art and science of the smile. I hope you enjoyed my lecture. It's part of my series, The Art and Science of the Smile. Truly a new way of doing and restoring implant prosthetics. If you have any questions, please feel free to contact me with the contact information given to you. Thanks again.